Hello, my dear aspirants. Welcome you all once again to the Master Nursing classes. So, in the last class of the mechanical ventilator, we have discussed the most important questions on the modes of the ventilation and very important image based questions and a very basic of the mechanical ventilation. And we have discussed the type of the respiratory failure, four complete type of the respiratory failure we have discussed and a GCS criteria that is less than 8, where we have adopt the patient for the mechanical ventilator. Why we asked to use the mechanical ventilator? The CPAP, BiPAP, PEEP, SIME, CME, everything we have discussed in the last video. And I am very much thankful to everyone, every Master Nursing Classes family member for supporting in a huge amount for the first video and for sharing the entire first video. So it actually motivates me and boosts me to give you a more important and more valid content for your exams. So I'm keep on updating you people regarding the all important questions. Okay, so last we have left with the best method of the weaning, that is the pressure support ventilation we have discussed. So that I have told. So in the question format also I have told you people that yes, which one is not a winning mode. Okay, in that one, so I have given the option SIME, CME, PSB and ACME. So in the last class I have discussed this one in detail, and so SIME, PSB and ACME are the weaning methods and CMV is not a weaning method. So the best weaning method is the that is pressure support ventilation. Okay, not useful in the weaning is the that's the controlled mandatory ventilation is not useful in the weaning. We have discussed this one. Okay, so and I have told if there is huge response for the first video, I will come with the second video also. So yes, as for my premise, I am here. So just your premise remain again. So please support to the every videos and keep on to your WhatsApp status and reach to the entire nursing community in the world. Okay, that is actually helps us to grow more and to give a valid and very valid content in the free of cost. Okay, so let us start with the today's class and all our live session. So please put up to hit the like button, and if anyone is watching directly a second video, so this here today in this today's video directly I am teaching the modes of ventilation. Already we have discussed, and here the settings of the ventilation I am discussing here. So if anyone is watching this video directly, you can watch this video because this is completely on the settings of the ventilation. So after this video you can go for the again the basic of ventilation, that is where I have discussed the modes of the ventilation. Okay, so if you have the basic knowledge of the ventilator, so why it is used, so what are the modes you have basic knowledge means, you can continue with this class also. Okay, not a problem, right? So again we'll start, right, without wasting the time. We'll start the particular today's video, that is what is the typical range of the tidal volume in adults during the mechanical ventilation. So you have started the mechanical ventilation to the adult patient. So what is the typical range of the tidal volume you have to keep? So tidal volume in shortcuts they will write VT. Okay, so what is the typical range of the tidal volume in a mechanical ventilator we have to keep? Okay, so first you people have to tell me what is the tidal volume, then what is the normal value of the tidal volume, then we'll go for the main answer. The tidal volume is the amount of air inspired during the each breath. Okay, so how much air we will inspire during the each breath, so that is what we call as the tidal volume. So normal amount of the tidal volume is the 500 ml. Okay, look at me. I took one breath. In this particular one breath, how much air I have took inside? So that is called as the tidal volume. So my tidal volume is the 500. Your tidal volume also a 500. So normal tidal volume also is the 500 ml is the normal tidal volume. So in the mechanical ventilator, what we are doing? We are mimicking the normal respiration only with the help of the machine. So again, I have to keep the mean tidal volume as a 500 in the mechanical ventilator. But here the weight is going to matter in the calculating the tidal volume in the mechanical ventilator. So how the weight is going to matter? So we have to keep 10 ml of the air per 1 kg of the body weight. Okay, in range 6 to 10 ml of the air per 1 kg of the body weight. So this is how we have to calculate the tidal volume. The examiner may throw the question in front of you people like, so patient of the 50 kg is in the ICU. Your intubated the patient and started the mechanical ventilator. So now as a nursing officer, you have to calculate the tidal volume for this patient. So how you have to calculate the tidal volume? Yes, you have to calculate the tidal volume. 6 to 10 ml of the air per 1 kg of the body, means the patient is 50 kg. Next, the for 1 kg 10 ml means for 50 kg it's for 50 kg it's 500 ml, right? So it is for 50 kg it is 500 ml. So this is how we have to calculate the tidal volume in the mechanical ventilator setting. Okay. So the question will come. The calculation of the tidal volume depends on which of the following factor of the patient. Option A, the age of the patient. Option B, the height of the patient. Option B, the weight of the patient. Option C, all the above. The only one factor which is responsible and which matters to calculate the tidal volume is the weight of the patient. Okay. So tidal volume will be calculated based on the weight of patient. Very important, right? So how we have to calculate, I have told here. So this is how it's very important to know the tidal volume to set in the mechanical ventilator. So let's come to the next very important question. So which of the following factor should be considered when setting the tidal volume in mechanically ventilated patient? Just I have discussed this question in the last slide only. So which of the following is a factor which should be considered during the setting the tidal volume in the mechanical ventilation? Option A, the patient's weight and ideal body weight. Yes, both are same. Patient weight and ideal body weight we have to consider as a factor to calculate the tidal volume in the patient before setting to the tidal volume under the mechanical ventilation. Okay, so all level of consciousness, temperature, and the type of the ventilator's mode. So these are not going to matter. So to deliver the tidal volume, the one thing that is influencing factor for the tidal volume is the weight of the body weight of the patient. Okay, so hope the concept is clear on that particular question. Okay, so here is the next important, very important question. What does FiO2 represents in the mechanical ventilation? So FiO2 means, consider this is the amount of the air, total amount of the air. So I am inspiring. So among this one, what is the concentration of the oxygen? What is the concentration of the oxygen in the inspired air? So that is what we call as the FiO2. That is the fraction of inspired oxygen. What it means? The fraction of inspired oxygen means, so this much of the air I am inspiring. Among that, how much oxygen is there? So that is the fraction of the inspired oxygen. So normally I have inspired this much here. How much concentration of the oxygen I have inspired? Just I have inspired the 21% of the oxygen, because the environmental air is having the only 21% of the oxygen. So fraction of the inspired oxygen we have to, how much we have to keep in the mechanical ventilator? That is from the 21% to the 100% is we have to keep it in the mechanical ventilator. Very important. So what's the FiO2? The fraction of the inspired oxygen. So option A is telling the rate at which the oxygen delivered to the lung. So the rate means that is the respiratory rate, we can say, or the flow rate of the oxygen delivery system, you can say. So this is not in FiO2. What I told, the FiO2 is the amount of the concentration of the oxygen in the total air, or so among the complete inspired oxygen, how much the fraction of the oxygen is there. Okay, so that is what we call the FiO2, the fraction in the inspired oxygen. So option B is telling here the fraction of the oxygen in air delivered to the patient. Yes. So total air we have delivered to the patient. Among those, how much fraction or how much part the oxygen is concentrated there. Okay. So that is the correct answer. Option B is going to correct answer. The fraction of the inspired oxygen means the fraction of oxygen which is there in the total air. So that is what we call as the FiO2. Then option B comes to the pressure excreted during the inhalation. That is not correct one. So option D, the tidal volume delivered to the lung. This is also not correct one. Okay. So the correct answer is the total amount of air is there. So among those total amount, how much concentration of the oxygen is there? So that is the FiO2 in general and simple language. Okay. Very important for you all. So then comes to the next question. What is the typically FiO2 we have to set in a range of the mechanical ventilator? So it's a single liner. Very important question it will come. So as I told, in the environment we are having the 21% of the FiO2. FiO2 of the environmental air is the 21%, means the total air is there. Among the 21% oxygen is there. Okay, so this is the FiO2 of the our environmental air is the 21%. Same To mimic the normal respiration, we will keep the 21% also, but the patient is unable to maintain his normal saturation with 21%, means we can gradually increase and until we can increase till the 100%, but complete respiration failure and all those things we can give the 100%. Otherwise, the low FiO2 only we will keep. Okay, so the total range of the FiO2 in the mechanical ventilator we can keep is the that is 21% to the 100%. So that is the correct answer for everyone, right? So here is the next question. Please do read the question completely. Yes. What does PEEP refers in mechanical ventilation? Already discussed the question in the last video. That is the positive and expiratory pressure. Means positive pressure means the pressure we are giving from the outside to inside at the end of the expiration. So that is what we call as the positive and expiratory pressure. The word itself it is telling at the end of the expiration we are maintaining the positive pressure in the lungs. Why we are maintaining the positive pressure in the lungs? Yes, the positive pressure becomes zero means the alveoli will get collapsed. So we are maintaining the positive pressure at the end of the expiration means the alveoli will not collapse. So that is the main what we can say the main reason for the maintaining the positive pressure or the PEEP at the end of the expiration to prevent the alveolar collapse. Okay, so option A is telling what actually question is asking what actually the PEEP is meaning in the mechanical ventilator. So let us read the option. Option A is telling the pressure applied to the lung during the inhalation. No, it's not in any kind of the pressure which is applied uh, on the lungs during the inhalation. So it is at the end of the exhalation, the how much pressure remains inside the lung. So that one is the PEEP. Okay. So option B, the pressure applied to the lung at the end of the exhalation to keep the alveoli open. Yes. So this is the correct answer. PEEP is the at the end of the exhalation. At the end of the exhalation, to keep the alveoli open, we need to maintain the pressure. So that is what we call as the positive pressure. Sorry, that is what you call the part of the positive pressure. That is the PEEP. So that is the positive and expiratory pressure, the correct answer. So option B goes here as the correct answer. Then to the C, it studies the rate at which the oxygen delivered to the lung. So this is also not correct one. Then option D, the volume of the air delivered to the lung at each breath. So the volume, how much amount of the air we are delivering to the lung at each breath. So this tells the, yes, what it tells. Bacho, anyone wants to answer? The volume of the air which is delivered to the lung with each breath is the, yes, our tidal volume, right? So this is the correct answer. Option D is for the tidal volume, but the examiner asking the PEEP, we have to respond for the PEEP. The option B goes to the correct answer for this particular question. Okay, so hope it's clear for everyone, right? So then here is the next question, that is what is the typical range of the PEEP in mechanically ventilated patient? In mechanically ventilated patient, what is the typical range of the PEEP we have to maintain? Just it is already discussed the question in the last question. Okay, so as I told, minimum we have to maintain the 5 mm Hg and maximum we can keep up to 10 mm. Sorry, minimum we have to maintain a 5 centimeter of STO. The same in some book they have given 5 to 8 mm of Hg also. Okay, so in some book they have given the 5 to 10 centimeter of H2 also, but here the mm of Hg till 8 only we can keep, not more than 8. For the centimeter of H2, it's we can keep till 10 also. Okay, so the best answer you consider you people is the 5 to 10 centimeter of H2 is the only. This one only people will consider as a normal PEEP. Only examiner asking what is the normal PEEP. The single best answer is the 5 centimeter of S2O is the normal, positive, and expiratory and pressure. Okay. So if option is telling 0 to 5, but at the end of the expression, the pressure is 0, means the alveoli will get collapses. So I'm not putting the answer as a 0. So I'm eliminating the option A. So then comes to the option C. There is the 15 to 20 centimeter of S2. When the PEEP will increases, means at the end of the expression also there is over pressure at the alveoli, means alveoli will get damages, alveoli will get damages due to pressure, due to pressure. So alveoli is damaging due to the pressure means we call this one as in the barotrauma of the lung. Okay, so where we should not keep the PEEP up to the 20 and 30. Okay, so this option C and D I am eliminating, and the correct answer is the typical range of the PEEP we can keep in the mechanical ventilator is the 5 to 10 centimeter of S2 is the correct answer. Okay, then comes to the next question. So which of the following is a formula to calculate the minute ventilation? What is the minute ventilation? The word itself it is telling for 1 minute how much air is going inside, how much air is coming inside. Okay, so how much air is going inside and coming outside, so that is what we call as the minute ventilation for 1 minute. Okay, so how we have to calculate this one? Okay, minute ventilation is, so for one breath how much air is going inside, that is the tidal volume. Okay, for one breath how much air is going inside, that is the tidal volume. For 1 minute how much time is tidal volume is we are taking for the 12, 13, 16, because the respiration rate for the 1 minute is the 12, 16, and 13, right? So up to 22 it's a normal. 12 to 22 is the normal respiration rate. So here to calculate the minute ventilation means for 1 minute how much the air went inside means just we have to multiply tidal volume with the respiratory rate. So let us search this particular answer in the options. Option A, the minute ventilation is equal to tidal volume into respiratory rate. Yes, so this is the correct answer. Tidal volume into respiratory rate we are doing here, but option B is telling minute ventilation tidal volume divided by respiratory rate. So do focus in the exam also. It's not divided by. It's a multiplication between the tidal volume and the respiration rate. So that gives us the minute ventilation. So rest all options are just given for the direction purpose. So don't take that one as a serious. Okay, so take this particular answer option A. The minute ventilation is equal to tidal volume into respiration rate. Okay, not divided by. Okay, so this is the very important for all you people. Okay, the next question is which of the following is a potential benefit of using the Sigh? Okay, using the Sigh breaths during the mechanical ventilation. So what is the Sigh breath? Sigh breath means, as I told, here we have to keep the tidal volume as a 500 ml. Okay, in the first question, just I told the range of the keeping the tidal volume is the 500 ml, right? So what I told 500 ml. Okay, consider. So here is the patient. I have kept the tidal volume as a 500 ml and patient on the mechanical ventilator since from the last 3 months. Okay, continuously 500 ml air only going inside and 500 air only coming outside. There are 500 ml only air only going inside and 500 air ml only coming inside. Oh, sorry, outside. Okay, means the lung will expand this much, collapse. This expands, collapse, expands, collapse. But when the patient comes out of the ventilation, now he is walking on the road. The dog is behind the patient. So now he want to run. He is unable to run because of the breathlessness, because his particular chest of the patient is expanding only this 500 ml only, then he is collapsing because last 3 months the patient lung is expanding this much only. Means the atrophy of the muscle happened in the when the patient is on the mechanical ventilator, and the lungs compliance the patient lost. What is the compliance of the lung? Compliance of the lung means expandability of the lung. So since from last 3 months patient is lung is expanding this much only and collapsing this much only, means when the patient will come out of the ventilator the patient muscle atrophy happens and the patient muscles will not expand much. Okay, it will expand the how much means only 500 ml only it will expand. When the doggy comes in behind the patient, the patient wants to run, so now his respiratory system is not supporting because of the atrophy it's expanding little bit only. So in order to prevent this one, in order to prevent the atrophy of the muscles of the respiration, and in order to maintain the compliance means the expandability of the lungs, so there is one mode in the ventilator, that is the Sigh mode. What it indicates, it delivers like first breath 500 ml, second breath 500 ml, third breath 500 ml, fourth breath 500 ml, fifth breath it will deliver the 1000 ml and the lung will expand this much. Okay, again the next 7th 500, 8th 500, 9th 500, 10th 500, like it will delivers in middle of the ventilation, it will deliver the double tidal volume, okay, our lungs will keeps on expanding more than the our tidal volume. Okay, so it will helps to maintain the expandability of the lung after coming of the patient out of the ventilation. Okay, so this is the reason to deliver the Sigh. Okay, so what is Sigh? Sigh is the uh, a large breath between the tidal volume to maintain the lung expandability, to maintain the lung compliance, and to prevent the atrophy of the lung chest muscles. So that is what we call as the Sigh, right? So in the question, what it asking? So it can be a right. So option A is telling it can lead to a respiratory alkalosis. No, bacho. Continuously hyperventilation happening means so that leads to the respiratory alkalosis. So in between the 15 breaths, one large breath I am giving just. So it won't be goes to till respiratory alkalosis. So option A I am eliminating. Then comes to the option B. It helps to maintain the lung compliance by preventing the alveolar collapse also, and by maintaining the preventing the atrophy of the chest muscles also. Okay, so this is the correct answer. So the Sigh helps to maintain the lung compliance and preventing the alveolar collapses. So this is the correct answer. Then option C comes here. It decreases the amount of oxygen needed by the patient. Okay, so yes, the Sigh, it will won't helps like this. Just the function of the Sigh is to maintain the lung compliance and to prevent the atrophy of the chest muscles. Okay, that is the reason. So option D is it reduces the tidal volume requirement. No, it won't reduces the tidal volume requirement. So option eliminating, option D also I am eliminating here. Okay, so this is the reason of the Sigh is to maintain the compliance of the lung and maintain the expandability of the lung by giving the one extra breath in between the normal tidal volumes, right? So that is the correct answer. So here is the next question. What is the normal I is to E ratio in mechanical ventilation? So what is the I to E ratio? That is the inspiration is to expiration ratio. So what is the normal inspiration is to expiration ratio? We have to maintain in the mechanical ventilator. Normally, what is the inspiration is to expiration ratio? Normally is the 1 is to 2. Same, the mechanical ventilator we are using to mimic the normal function. So in the ventilator also, the best one we have to keep as the inspiration to expiration ratio is the a short cycle of the inspiration followed by the long cycle of the exhalation. So how it helps the inspiration to expiration ratio? Bacho, the inspiration cycle is short, means I am delivering the oxygen inside. Okay, the exhalation cycle is long, means the entire remaining air and the carbon dioxide will come outside. So if I keep the inspiration ratio more, means it was keep on delivering the oxygen more. So there may be a chance of the damage to the alveoli. So it may lead to the barotrauma. Okay, barotrauma means the alveoli will get ruptures because of the pressure. Okay, alveolar ruptures means the air will leak into the pleural cavity. So there is chance of the yes, there is chance of the pneumothorax. Because of the damage of the alveoli, the air will leak into the pneumothorax. Okay, so which type of the pneumothorax? It causes the tension pneumothorax. So what is tension pneumothorax? The air will enter inside and there is no space to escape for the air because the ventilator keeps on delivering the oxygen with high pressure. So the air will won't escape back. Okay, so if because of the barotrauma, the tension pneumothorax happens. So if this tension pneumothorax also we won't control, means the pleural cavity also will be ruptures and the air will go into the mediastinum. So the pneumomediastinum also happens. Okay, pneumomediastinum also happens if we are giving the high pressure and if we are keeping the inspiration rate or inspiration cycle as a long. Okay, that is what the inspiration cycle should be short, means only one half of the cycle, then the exhalation should be long. Okay, okay, the remainder and retained air may go outside. Okay, so that is the reason. So where the inspiration is to expiration ratio in the mechanical ventilator need to keep 1 is to 2. Okay, so that is the reason and this is the answer. So here is the next question for you people. A most important, very, very important, right? The question is, what does the alarm fatigue refers into the context of the mechanical ventilation? What is the meaning of the alarm fatigue? What is the meaning of the alarm fatigue in context of the mechanical ventilator? Alarm fatigue is simple thing. Consider you as a nursing officer, you are posted in the ICU. Okay, so these are many of the nursing officers posted in the ICU, and here is also monitor, here is also monitor, here is also monitor. Okay, there are lots of the monitors are there. which are continuously beeping the sound twink, 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 continuously sound will be there. Till the starting of the shift, till the end of the shift, the sound will be continuously coming. So when the person exposes to this particular irritation repeatedly, it's normal human behavior to avoid this particular alarms. Okay, if sound also coming means you will sit like this only. You will not going to assist the patient because you know that the sound is continuously beeps without any reason. So when the healthcare providers creates the resistance to response to the alarms. So this is what we call as the alarm fatigue. Means the patient, the alarm is beeping there because of the repeated exposure. We got the fatigue like छोड़ दो यार कुछ नहीं होता. Like this kind of the attitude will develop. Okay, so this is the what we call as the alarm fatigue. In order to prevent this one, we have installed the two set of the alarm. One is the high pressure alarm, one is the low pressure alarm. Continuous alarm is not preferred. So make switch the continuous alarm off. Okay, only when there is obstruction is there, only when there is disconnection is there, then only the alarm should beep. Okay, so in order to reduce the alarm fatigue, we have started the high pressure alarm, low pressure alarm. That's it. Okay, so very important. So what is the meaning of the alarm fatigue in context of the mechanical ventilator? Option A is telling the inability of the ventilator to produce the accurate alarm. No, ventilator will produce its alarm, but we are unable to respond to that alarm. That's what you call as the alarm fatigue. So option A, I am eliminating. Option B, a patient's physiological response to the ventilator alarm. It's not patient response, it's a healthcare provider response. Okay. So then comes to the option C. The desensitization means the sensitivity got lost, okay, or decreased response by the healthcare provider to a frequent alarms. So this is what you call as the alarm fatigue. It's very important, bacho. Then option D is the mechanical failure to the ventilator alarm system. Okay, so it's not in option D also correct answer. Option C goes the perfect answer here. So that is what you call as the alarm fatigue during the mechanical ventilation. Let's come to the next question. Which of the following is the most accurate cause of the high pressure alarm on the ventilator? The most accurate cause of the high pressure alarm on the ventilator. Bacho, remember the mnemonic on the mechanic ventilator alarm. So that is the hold. This particular mnemonic already we have shared in our WhatsApp groups multiple times. In our Instagram channel of the Master Nursing classes also this mnemonic is there. It is there in our Master Nursing class app pre-contained also the ventilator alarm mnemonics. So we have added in our app also because it's an important. So one more important thing I want to tell you people, we have the beautiful Telegram group where continuous quizzes will be going free of cost for the aspirants, and we are having the beautiful WhatsApp group where the 4,000 plus aspirants keeps on discussing their questions, keeps on discussing their doubts in our WhatsApp group. Whenever we will get time, I am particular myself. I will respond to their some questions if it's necessary. Otherwise, the aspirants themselves they will solve the question if necessary. Otherwise, myself I will directly solve that question in your WhatsApp groups. Okay. So and we are having the beautiful MNC app also, the Master Nursing Classes app also. For that, in that particular app, we are running the most important Vande Bharat test series for the upcoming RRB exams, and we are running the NORSET booster test series for our upcoming NORSET 8. And if you want both Vande Bharat and NORSET 8 test series, we are having the very important test series package, that is the Sure Selection test series. This is for the both RRB and NORSET. If you want, you can download the Master Nursing Classes app. I have given the link below the description box and in the comment box also. Okay, if you want that one, you can go for that one also. It's a very important thing. So let me go for the our main concepts of the ventilator alarm mnemonics, right? So let me remove this one. So what is the hold? H means here the high pressure alarm. Okay. So high pressure alarm. H means here is the high pressure alarm, right? So when the high pressure alarm happens, means when the patient will blocks the tube, means when the patient will bites the tube, means the tube will get black. Okay, consider this is the tube. When there is obstruction in the tube, means the pressure will be increased in the tube. So this increased pressure, it will send the response to the ventilator. So then the high pressure alarm will generates. So whenever the pressure will be increasing in the tube, consider if the patient bites the tube here, okay, between the teeth of the patient is biting the tube, means the pressure is building in the ventilator circuit, the high pressure alarm will come, and the patient is sleeping on the tube, means the tube will kink here. Okay, so the tube will kink here, so then also the pressure inside the tube will increases means high pressure alarm will come. When the tube kinks, when the tube blocks, when there is an secretion in the tube which completely blocks the tube, so again the overload of the secretions, kinking of the tube, blocking of the tube. Okay, so and biting of the tube where the tube is getting blocked. Okay, or the tube is getting obstruction, then the pressure inside the tube is increasing. So it will increase the pressure in the tube, which will deliver the high pressure alarm. Okay, it will deliver the high pressure alarm. So whenever the high pressure alarm delivers, what we have to assess? We have to assess for the kinking of the tube, biting of the tube, obstruction in the tube, and yes, these are the things we have to assess in the high pressure alarm. So whenever there is leak of the air from the tube, okay, so whether it may be this tube is disconnected from the our ET tube or the tracheostomy tube, or the tube may got hole where it is leaking the air, means whenever there is the leaking the air, the pressure in the tube is very low, so which will cause the low pressure alarm. Low pressure alarm. So there is low pressure in the tube, means it will produce the low pressure alarm. So if there is low pressure in the alarm, what we have to assess is we have to assess for the disconnection between the tube and the ventilator circuit. Okay, so if there is disconnection between the tube and the ventilator circuit, means so it will provide the low pressure alarm. So to remember this one, high pressure alarm for obstruction, low pressure alarm for disconnection, and disconnection between the tubes. Okay, so that is the very important. Then the priority nursing intervention comes. You are working as a nursing officer in the ICU. Okay, this is a ventilator machine we are having, right? So here is the circuit, ventilator circuit will come, and it is attached to the patient. Okay, so you are sitting as a nursing officer in your nursing table and you are monitoring the patient. Now the high pressure alarm started. The high pressure alarm started. So where you have to see first? You have to see first as a ventilator problem, or where you have to see first as a patient problem. Yes. So to which particular part you will give the first priority, whether you have to assess for the patient or whether you have to assess for the ventilator. So whether it may be a high pressure alarm, whether it may be a low pressure alarm, always give first priority to the patient and always assess the first to the patient only you have to assess. So assess the patient for all the possible things that may be a bite of the tube, kink of the tube. Okay, so whatever it may be, first priority you have to give to the patient itself. So that's the very important concept and question. It will comes in your exam. Okay, so yes, I think it's clear to everyone. So then comes to the our important question: which of the following is the most common cause of the high pressure alarm in the mechanical ventilator? Okay, so option A, yes, high pressure is for the obstruction. Simply airway got obstructed because of the mucus plug blocked the airway. So pressure in the airway is increasing, and because of the kink of the ET tube, the pressure in the airway is the increasing. So there is resistance in the airway because of the mucus plug, because of the kinking, and there is increased pressure leads to the high pressure alarm. So the option A goes to the correct answer. Then low tidal volume is there, means low pressure alarm will come. Low inspiratory pressure means low pressure alarm will come, and insufficient oxygen supply also low pressure alarm come, and mainly leakage of the air and disconnection of the tube. So always low pressure alarm will comes. Okay, so this is the very important thing all you people have to know and understand and give the best to the shot in your upcoming exam, right? So next one is What is the most common cause for the low pressure alarm on mechanical ventilators? On the mechanical ventilator, so we are getting the low pressure alarm. So what is the most common cause? So option A, high airway resistance. But in the airway or in the tubing, the resistance is increased or high means we will get the high pressure alarm, not the low pressure alarm. I am eliminating the option A. So then comes to the next option. There is a patient disconnection from the ventilator circuit. Yes, the patient tube is disconnecting from the ventilator circuit, and because of this disconnection the air is leaking. Means the air is leaking means the pressure in the tube is decreased, so the low pressure alarm will generate here. So this is our correct answer. Option C is tells here the increased inspiratory pressure. The inspiratory pressure is increased. So what it means? Again, the inspiratory pressure increased means the high pressure alarm will come. Excessive tidal volume. The low tidal volume I told here is the low tidal volume I told here is that is we will get the low pressure alarm. If the patient is having the excessive tidal volume, we will get again the high pressure alarm. Okay, here also high pressure alarm will generate only in the patient disconnection from the ventilator circuit. Then there is chance of the low pressure alarm. It's very important. Okay, so here is the next question. So please do read the question completely till the end and try to give the best response to this question. While discussing the last question, I have clearly given the idea on this one. Okay. Yes. What is the primary cause of barotrauma in mechanical ventilator patient? So barotrauma means baro means again always consider baro means the pressure. Okay, we are having the baroreceptors. Baroreceptors are the pressure sensitizing receptors in the our carotid artery. So where if increased blood pressure, which sends the signals to the brain, the blood pressure is increased. So the brain will sense the parasympathetic activity. So activation of the parasympathetic nervous system, the blood pressure will decreases. So the because of it happens because of the baroreceptors. So baroreceptors are pressure sensitizing receptors. Again, here the baro means the pressure. Okay, the barometer we are having the pressure monitoring meter, the barometer. Okay, so like the barotrauma means because of the increased pressure, the trauma is happening to the lung in the mechanically ventilated patient. So, what is the primary cause for this one? So, it is primary cause is the increased pressure in the alveolar level. So, when the increased pressure in the alveolar level happens, whenever there is increased in the positive end expiratory pressure is increased. Okay, normally I told this one is the 5 to 10 mm of centimeter of H2O. So this is the normal. If it's going more than 10 centimeter of H2O, that may be a 20-30 centimeter of H2O, or if there is closed system ventilation which is completely and continuously giving continuous air, and it's continuous mandatory ventilation where the patient also taking the breath and the ventilator also pushing the air proper continuously, means because of the increased pressure in the thoracic cavity, the lungs and alveolar tissue will get damages. So that is what we call as the barotrauma in the mechanical ventilation. So what is the primary cause for this one? Option A, low tidal volume. Low tidal volume means low pressure. Low pressure means the trauma will not happen. So option A I am eliminating. Then comes to option B, high inspiratory pressure. So during the inspiration there is increased pressure. Yes, this may leads to the damage to the our lungs because of the increased pressure. Then comes to the option C, excessive oxygen delivery. You are delivering the excessive oxygen, which leads to the the hyperventilation and the respiratory alkalosis it causes. Okay, it's not causes the barotrauma. Then option D, decreases the respiratory rate. The rate decreased means the the air pressure also decreased, so it will not cause the barotrauma. I'm eliminating the option D also. So the correct answer for this question is the excessive and high inspiratory pressure, which leads to the barotrauma in mechanical ventilated patient. Hope the concept is clear for that one. So let's discuss the next question. So this one is the which of the following strategies can help to elevate? Bacho, wherever the word elevate which comes, the meaning is increased. But wherever the word elevated comes, yes, that meaning is to decrease. Okay, elevate is to decrease, elevate is to increase. Okay, so here, which of the following strategy helps to elevate means to decrease the hypotension in mechanically ventilated patient with elevated intrathoracic pressure. So high hypotension happens in the mechanically ventilated patient. Let me clear your concept here, bacho. So here are the I am going to cover the very important concepts that is very much necessary before going to your exams. Okay, all of you people know that these are the lungs. Okay, so these are the two important lungs we are having. In between these lungs, here is the heart, right? So here is the heart, and from above the superior vena cava is coming, from the below the inferior vena cava is coming. Whenever you are giving the positive pressure ventilation, these lungs expands. Okay, so these lungs expands like this. These lungs expands like this. If we give the more positive pressure ventilation, it will compress the our superior vena cava, inferior vena cava also. So these are the two very important major vessels which bringing the blood back to the heart. Okay, because of the increased intrathoracic pressure, there is creation of the pressure on the superior and inferior vena cava. So the cardiac return means the blood of returning to the heart will decreases. So blood supply back to the heart decreases means the cardiac output will decreases, right? So the cardiac output will decreases means the blood pressure is also decreases. So the question will come whether the hypertension. What happens in the mechanical ventilated complication means the hypotension happens, right? Decreased blood pressure we call as the hypotension. And one more thing, the very important, whether the weight gains or weight decreases in the mechanical ventilated patient means weight gain happens. How means, okay, I think the hypotension concept is clear because of the intrathoracic pressure. So the hypotension happens here. So to correct this hypotension, what we have to do, we have to reduce the intrathoracic pressure, means we have to keep the positive and expiratory pressure low. Okay, reduce the positive and expiratory pressure, that controls the hypotension. That is the treatment of the hypotension and the mechanical ventilator pressure, to keep the PEEP as a low. Okay, so as I told here, because of the pressure on the superior and inferior vena cava, the cardiac return decreases, the cardiac output decreases. Means cardiac output is decreases means the blood supply to kidney also decreases. The blood supply to kidney also decreases means urine output also decreases. Means the fluid will retain inside the body. Okay, fluid will retain inside the body. The fluid is retaining inside the body. As a complication of the mechanical ventilation, weight gain happens. Okay, because of the fluid retention, weight will increases. Right. The barotrauma is the complication of the mechanical ventilation. Hypotension is the complication of the mechanical ventilation, and weight gain is the complication of the mechanical ventilation. So these are the all most important complication of the mechanical ventilations. So we have discussed here. So then comes to the yes, alveolar rupture and barotrauma is the same thing that is happening here. So these are the things which are considered as the complication of the mechanical ventilation. And here I told during the barotrauma, yes, during the barotrauma, what I told, the alveoli will rupture, the air will go into the pleural space, the tension pneumothorax happens. Okay, so because of the tension pneumothorax, yes, the pleural space also will get ruptured. Because of the ruptured pleural space, the air enters into the mediastinal cavity, the pneumomediastinum also will happen. Okay, let me revise quickly the complication of the mechanical ventilation. Barotrauma, because of the barotrauma, tension pneumothorax, because of the tension pneumothorax, pneumomediastinum, right? The three complication, most importantly, and the hypotension, because of the increased intrathoracic pressure, hypotension happening, and because of the hypotension, less blood supply to the kidney and decreased urine output will also happens. Okay, so along with that, the decreased urine output means the increased water retention in the body, means the weight gain also will happens in the mechanical ventilation complications. Hope that yesterday's video and today's video is completely helpful on the mechanical ventilation. Okay, so in the last video we have discussed the why the ventilator is necessary, how it works, what are the modes, types of the respiratory failures, CPAP, BiPAP, and PEEP. Everything we have discussed in the previous class. And in the today's class, we have discussed the most important questions on the all settings of the ventilator, where and all complications of the ventilator, and few questions on other things also we have discussed here. Okay, so this is the more than enough content and more than enough quality content for you people to study on the mechanical ventilator. So whoever watched the video, if you want notes again, you can watch the video and take you complete your own handwritten notes and whatever the thing I have said, that one also make right and revise before the exam. If the questions comes on the mechanical ventilator, it will comes in the three or four numbers. Okay, so that is going to very much helpful. And these simple settings like what is tidal volume, how to set the tidal volume, what is the FiO2, how to set the FiO2, okay, and what is the P, what is CPAP, what is BiPAP. These are the repeatedly asked questions the examiner keeps on throwing you people. Okay, so and this is also very much simple, very much important. So all minor to minor to major components I have discussed on the mechanical ventilator. Still you people have any doubts on the mechanical ventilator, so please do mention your doubts in the comment box. So I am always ready to respond to your syllabus related or topic related doubts. Okay, so if you have any other doubts also, like recruitment related doubts, you comment those doubts under the our notification videos, and also there our team will respond for that one. Okay, so if you have any subject related doubts, whatever it may be, anatomy, physiology, psychology, psychiatric, whatever it may be, nursing subjects, you have doubts, so please do mention the doubts. I will try to respond and try to mention your doubts specifically, what actually what you want to ask, so it will give clarity and I will give clarity to you people. Okay, so if you have any doubts, you can ask those doubts in our WhatsApp group also. So that is helpful for you to get more clarity, and other aspirants also, which will help you there in our WhatsApp group, right? So to join our WhatsApp group, Telegram group, and to download our Master Nursing Classes app, so I have given the links in the description box, in the comment box. So you want to go for the comment box, so make a 5 to 10 thumbs up in the comment box, then join to our WhatsApp group, Telegram group, and MNC app. So it will deliver you a highly quality content with updated knowledge. So we'll meet again in the next session. Tab tak ke liye, Jai Hind, Jai Bharat. Don't forget to subscribe to the class. Okay, and if you love the content and if you love the quality of the content, please hit the like button. That actually boosts us, motivates us to give the more content towards you people. We'll meet again in the next class. Tab tak ke liye, Jai Hind, Jai Bharat.